We'll go on to Steve Bailey, who's going to talk more about retinal breaks, but also go into retinal detachment.
Thank you. I'd like to start by thanking the Academy. I feel very fortunate that we, in our field, can make clinical decisions based on evidence-based data. It makes us feel confident in what we do. And I'd like to thank Dr. Flaxel and the rest of the committee members for a great experience as we put these PPPs together. And I have no financial relationships or interest to disclose. So Rhegmatogenous retinal detachment is sort of the one aspect of that we've been discussing about of what we hope to avoid or we hope to appropriately monitor for. And the risk for developing a Rhegmatogenous retinal detachment is about 12.6 per 100,000 persons in the primary white population, and a lifetime risk is about 1 in 300 people. Increased risk factors include myopia, family history, a fellow eye with a retinal tear detachment, a recent vitreous separation, trauma, peripheral lesions, vitreoretinal degenerations, and a posterior capsule rupture with vitreous loss, which increases the risk of Rhegmatogenous detachment by 20-fold. The clinical signs and symptoms are similar to what we discussed about in these earlier talks. This includes vision loss, visual field loss. Some detachments are actually asymptomatic, and these are found during routine exam, or flashing lights and floaters. The typical clinical signs are potentially reduced visual acuity or possibly an afferent pupillary defect, as well as sometimes you'll see a lower intraocular pressure in the eye with the retinal detachment. Schaefer sign is when you identify pigmented cells that are visible in the anterior vitreous. Oftentimes, retinal detachments will appear as a convex retinal elevation that progressively extends from the periphery to the optic nerve head, and additionally, many times these may be associated with vitreous hemorrhage. So when you first encounter someone who may have retinal detachments, it's very important to take a history, as been previously discussed. You want to know the duration of the symptoms, and you need to dilate both eyes. That ends up being very important because the other eye may have asymptomatic pathology or things that may help you learn more about this person's overall eye health. During the complete eye exam, the key question to ask is the macula attached or not? Typically, if the macula is not detached, then surgery is done emergently, or if the macula is detached, then surgery is not as urgent, often done within about 1 week. There may be vitreous hemorrhage with the retinal detachment, and so vision may be poor, but they still may have a macula on retinal detachment. So it's very important to do an ultrasound to get sort of a complete idea of what's going on in the structure behind the vitreous hemorrhage. Here's an example of a macular-sparing Rhegmatogenous retinal detachment. You can see a large bullous detachment superiorly with the retinal break highlighted with the blue arrow. You'll also notice that sort of on the posterior border of that, there's a sort of a slight sort of lighter orangish area where that's actually sort of a little bit of subretinal fluid that's marching toward the fovea that's not part of the bullous detachment. So oftentimes if you look carefully, you'll see the bullous elevation, but then you also see this leading edge of shallow subretinal fluid, and you can just sort of see that area of shallow subretinal fluid on that OCT, and then you see at the superior edge of that, the OCT starts going up as you encounter the bullous portion of the retinal detachment. The basic pathophysiology of a Rhegmatogenous retinal detachment is that there's a tear in the retina, and oftentimes these tears have traction, which keeps that tear open and allows a conduit for the vitreous fluid to track underneath the retina and result in a retinal detachment. Oftentimes, it's important to use Linkoff's rules to help identify a break. We can identify a break in about 90 to 95% of eyes with a Rhegmatogenous retinal detachment. If you look at Linkoff's rules, if you have a detachment where it's primarily an inferior detachment, 95% of the time the tear will be on the higher side of the area of the detachment if you compare the temporal versus the nasal side. If you have a primarily superior detachment with inferior fluid, about 93% of the times you'll find the tears in the top 2 clock hours between 11 and 1 o'clock. If you have an inferior retinal detachment, typically the tear will be on the side that's higher, as shown in the image for rule number 3. And finally, it's important if you see an inferior detachment, sometimes you have these real sneaky holes that are superiorly, and the fluid drains around the periphery, and then there's a large sort of bullous collection of fluid inferiorly. And the other additional rule I like to add to my fellows in our clinics is don't assume there's one tear. Oftentimes there are more than one tear, and that's important as part of our surgical planning and our decision making. So we also have to remember that if you see a retinal detachment, there are 3 different types of retinal detachment, and it's important to differentiate these because this has significant management implications. So we know the word rhegmatogenous comes from the word rhegma, which means break, and we discussed the pathophysiology already, but it's really important that that break is found. If you don't find a retinal break, then you may need to consider about the other types of detachment, specifically tractional retinal detachment. These are associated with proliferative membranes that are on the surface of the retina, and these extend tractional forces that separate the retina from the retinal pigment epithelium. Or an exudative or secondary retinal detachment. These are retinal detachments that are due to diseases of the retina and choroid that result in fluid from the choroidal retinal tissue extending between the retina and the retinal pigment epithelium. Often these are neoplasms or inflammatory disease. Here's a nice table that can help us differentiate between these 3 types of retinal detachment. Typically, rhegmatogenous detachments will have the risk factors that we previously mentioned, and again, in most cases, you can find a retinal break, or you have pigment in the vitreous cavity. For tractional retinal detachments, oftentimes there's a history of an additional condition such as diabetes, prematurity, possibly trauma, sickle cell disease, or retinal vein occlusion. These cases, you oftentimes will not find a retinal break. The retina appears taut, and instead of convex, it appears concave on surface. And oftentimes, the detachment is limited posteriorly and doesn't extend out to the aura, whereas rhegmatogenous detachments are sort of the opposite. They tend to start in the periphery and move towards the center. If you're looking at exudative detachments, again, there's an underlying systemic cause. So if you has a detachment in your office and you can't find a break, it's important to think about what is the blood pressure in this patient. Could this patient be in renal failure? Could there be a mass such as a melanoma that's accounting for this retinal detachment that's sitting in front of you? Oftentimes, the volume is gravity dependent, and you can watch it move by shifting the patient's head. These often are smoothly elevated without folds compared to rhegmatogenous detachments. You do not see pigment in the vitreous in these cases. The other important differential diagnosis when you are dealing with a potential retinal detachment is retinoschisis. Now, retinoschisis is sort of a splitting within the retina, and these often do not progress and do not require treatment. The clinical features to distinguish schisis from retinal detachments include retinal detachments tend to be corrugated instead of smooth or dome-shaped, which is found in retinoschisis. Oftentimes, you will not see pigment or hemorrhage in retinoschisis. The scotoma in retinoschisis is considered an absolute scotoma, where there's actually no function within those areas where the photoreceptors. You can take your slit lamp and make a small beam and move into the retinoschisis, and oftentimes there'll be no perception of that. Whereas in a rhegmatogenous detachment, they'll still appreciate the light, but it'll just be dimmed and less noticeable. And oftentimes you will not see shifting fluid with a schisis retinal detachment. One other key difference that I really like to use is oftentimes senile retinoschisis is bilateral. So if I see something that's suspicious for schisis, I oftentimes will look in the other eye temporally or supratemporally, and seeing that is really reassuring to me. Here's a clinical image of a retinal schisis where there's also an outer retinal hole. This can be difficult to determine, is this schisis or is this a retinal detachment? And I'm not sure if this picture shows up real well, but what you can see is that there's actually retinal vessels that go, and you can see them coursing over the outer retinal hole. And so you know that's not an inner retinal hole, but that's an outer retinal hole that's found in retinoschisis. Diagnostics can be very useful when you're trying to determine the difference between retinoschisis and rhegmatogenous retinal detachment. In retinoschisis, you can oftentimes get your OCT out far in the periphery, and if you see sort of these stretched schisis areas with that residual retina tissue that's still adherent to the retinal pigment epithelium, you can be very confident that that's our area of retinoschisis as compared to rhegmatogenous retinal detachment. Other things that are useful include ultrasound and UBM, looking for more peripheral areas of retinoschisis and comparing those to retinal detachment. So as I mentioned before, the management varies on the type of detachment that you have, and we're going to focus on rhegmatogenous retinal detachment because that's the topic of this symposium. The key for treating a rhegmatogenous retinal detachment is to find the break, create chorioretinal adhesion around the break, and close the retinal break. And really, the basic techniques that we use commonly are laser demarcation, pneumatic retinopexy, scleral buckle, and vitrectomy with fluid drainage of subretinal fluid. Once the retina is reattached with vitrectomy, we often use gas bubbles and silicone oil for a tamponade after the fact. And I'm going to kind of briefly discuss about our approach to many of these types of retinal detachments. So observation or laser demarcation is often used for chronic small peripheral retinal detachments that are often asymptomatic. Dr. Lin already defined what a subclinical detachment is, and I'll just repeat that here. This is when you have subretinal fluid extending more than 1 disc diameter from a retinal break, and the fluid does not extend more than 2 disc diameters from the equator. Other signs of chronicity include pigment demarcation lines. And it's important to note that just because you have a chronic detachment, whether you treat it with laser or observe it, that these still are at risk for detachment, and they do need to be monitored closely. Here's a patient from my clinic that came in just a week ago whose other eye had a retinal detachment, and you can see in the inferior nasal quadrant there's an area of lattice degeneration with a retinal break and a small collection of subretinal fluid that's greater than 1 disc diameter. This was a lesion that I treated with vitrectomy. It's fairly posterior. It'd be difficult to buckle that, and we decided not to do a vitrectomy, and so this was treated with laser. And she already had a PVD, which was 3 years ago. So the other in-office technique to deal with retinal detachments includes the pneumatic retinopexy. This is often done with regional anesthesia and can pretty in most cases, be done in the clinic. An intraocular gas bubble is used to close the retinal break. This allows the subretinal fluid to be absorbed on its own by the retinal pigment epithelium. Now the break is closed, but it still needs to be sealed. And so it's sealed with either cryoprexy, which is done prior to the treatment with a gas bubble, or it's done with laser treatment, and where you put the bubble in first, the retina flattens. In the next couple days, you can apply a laser around the break when the retina is attached. The bubble then remains there over the next several week or so while the chorioretinal adhesion forms. And you monitor these eyes very closely because you want to make sure that the adhesion is obtained and the retina remains attached once the bubble is gone. So it's very important when you're dealing with pneumatic retinopexy to consider patient selection. You have to have confidence that you've detected all retinal breaks, and ideally all these breaks are found in the superior 8 clock hours. You need clear media, and so you may think twice about doing a pneumatic retinopexy on someone who has a lot of capsular phimosis or something where the exam is limited. Additionally, we tend not to do these unless there's only a single break or breaks that are within 1 to 2 clock hours of one another, and you want to make sure there's no evidence of tractional forces such as proliferative vitreoretinopathy or vitreous hemorrhage, which can confound and make the treatment more difficult. Additionally, these patients need to be very clear the importance of strict follow-up and positioning as they're healing. So prospective clinical trials have found that the success rates of pneumatic retinopexy in the appropriately selected patients approaches 73 to 80%. Complications with this include subretinal gas migration, anterior chamber gas migration, endophthalmitis, cataract, possible recurrent RRD from formation of new breaks or untreated retinal breaks. Scleral buckle is another procedure that's done. This is an extraocular procedure, meaning we do not go inside the eye. This is often successful for younger phakic patients and patients that have an attached vitreous. This is not suitable for patients with extensive PVR or giant retinal tears, or this would be needed to do in conjunction with the vitrectomy surgery. The goal for this is to initially treat the retinal break with cryopexy to create permanent adhesion between the retina and the retinal pigment epithelium. The buccal material is then used to support the break, and this can be done either in a segmental fashion or encircling band. This is often performed in the operating room under regional or general anesthesia. In some cases, you may drain the fluid externally, especially in cases with chronic subretinal fluid or with bullous retinal detachments. Sometimes an intraocular gas bubble will be needed to further give you some reinforcement to get the retina attached. The success rates for scleral buccal surgery is between 80 and 90%. Many of the questions that come up is there metal in these? Can we use an MRI? And the answer is yes. It's also okay for air travel. Oftentimes these patients may have induced myopia, astigmatism, anterior ocular ischemia is pretty rare but possible, diplopia, ptosis, orbital cellulitis, subretinal hemorrhage from drainage, and retinal incarceration at the drainage site. Here's a case of a 20-year-old male who has a history of many altercations, and he came in with a chronic macula off retinal detachment with a number of large subretinal bands. Because the hyaloid was stuck down, we prefer not to do a vitrectomy, and we're able to get his retina attached despite those subretinal bands, and he's done well in the postoperative period. Of note, he also had an asymptomatic macula on retinal detachment, so both eyes had a scleral buccal placed in a matter of a couple weeks. So the other common technique used to repair retinal detachments is vitrectomy. The purpose of vitrectomy is to first remove the cortical vitreous responsible for the retinal breaks and to reduce chance of future break formation. The subretinal fluid is then typically drained during the surgery. This allows for reapposition of the retina, and then you can apply chorioretinal adhesion with either laser retinopexy or cryoretinopexy. And after that's done, then a tamponade agent, which is either air, gas, or oil, is then used to maintain retinal attachment during the next 5 to 7 days while the chorioretinal adhesion develops and it can hold on its own. This surgery is performed in the operating room with regional anesthesia and less frequently with general anesthesia. This is often a useful surgery if the breaks are posterior, if the breaks are in different meridians, if there's a giant retinal tear, concurrent proliferative vitreoretinopathy, and if detachments have accompanying vitreous hemorrhage. Oftentimes, we will use 3 ports to gain access to the eye. One port will be an infusion, which keeps the eye inflated during the removing of the vitreous cavity. And we'll have 2 working ports. One will have a light pipe to help us visualize what we see. The port placement depends on whether the patients are aphakic or pseudophakic, and pseudophakics are placed at 4 millimeters compared to aphakic patients or pseudophakics, which can be closer to the limbus. Premature infants have sclerotomies placed closer to the limbus because of their anatomy. There's been some significant improvement in the technique of vitrectomy over the years. We now use small gauge surgeries, which has been very useful and has made vitrectomy surgery safer. And part of this is that we use trocars, and this allows us to enter and exit the eye with less likely to get incarceration of retina or vitreous. And here's just an image of a vitrector probe and removing the vitreous cavity. We do use wide-angle visualization systems, which is very useful, but it's also very useful to have a scleral depressant, an assistant for scleral depression, which helps us identify breaks with dynamic depression and treat them. Once you've removed the vitreous cavity is then filled with an air bubble. The air bubble, while it is filled, this is what's called endodrainage. You have a separate hand that aspirates the fluid out of the vitreous cavity as well as the fluid out from underneath the retina. Once that's done, then you can apply the retinal break. An alternative is you can actually do an external drainage by taking a needle that goes obliquely through the sclera and the choroid into the subretinal space, and you can drain that with using an indirect ophthalmoscope. And finally, you can use heavy liquids or pleurophoron, which basically goes to the bottom of the eye, and as you fill it up with this heavy fluid, it'll mechanically express or push the fluid out from underneath the retina, and then you can apply the laser while the heavy fluid is in the eye, and then you can change to either a gas bubble or silicone oil for a long-term tamponade. And one potential downside with perfluorocarbon is you can get these small subretinal PFO bubbles that get underneath the retina. If they migrate to the fovea, that might affect the visual acuity. Here's a patient of mine who had some subretinal migration into the posterior pole. Luckily, this did not go into the fovea, and this has remained stable here. And this patient's been 20/40 for the last 8 years. Here's an example of another case where we'll use perfluorocarbon. This is a 7-year-old with Stickler syndrome. In the entire superior area, that's actually bare retinal pigment epithelium. The retina is flipped and folded over inferiorly, and so this is a case that would be very difficult to do without PFO, where you can inject PFO within that retina, and that sort of unwraps it and folds it back into the retina, and then you can apply a laser and put oil in the eye. So just briefly, the gas bubbles that we use, air is the shortest acting one that lasts for several days. The longer acting gases include SF6, which is 10 to 14 days, or C3F8, which lasts about 6 to 8 weeks. Silicone oil is very useful, especially with more complicated retinal detachments, because this can stay in on a longer time frame. You can watch for potential PVR or recurrent detachments to form. Complications include cataract, glaucoma, band keratopathy, and subretinal migration of the silicone oil. Complications for vitrectomy are numerous, and it's important that the patients are well educated about these prior to surgery. This includes cataract, long-term risk of open-angle glaucoma, intraoperative or postoperative retinal break, possible postoperative redetachment, cataract, vitreous hemorrhage, fibrin exudation due to inflammation, endophthalmitis, and phototoxicity. Oil specifically can also add risks of glaucoma, band keratopathy, and corneal decompensation. Proliferative vitreoretinopathy is something, and it's one of the most common causes for failure. This is a wound healing response, which entails growth of RPE glial cells that proliferate on the retina and cause taut traction, causing either tractional detachments or induce a tear in the retina, causing a retinal detachment with a break in it related to traction. Risk factors include trauma, large tears, youth, hemorrhage, prior inflammatory disease, as well as cryotherapy. Here are just some schematics of the surgical approach to proliferative vitreoretinopathy, where membranes are identified, dissected, and removed from the retina, allowing the retina to fold back into place and be treated. So overall, if we look at our overall success rate of retinal detachment repair for primary surgeries, between 80 and 90%. If there's PVR present, the primary success rate drops to 70%. Eyes with PVR, uveitis, choroidal detachments, or posterior breaks have worse outcomes overall, and our final rates of success with multiple surgeries is greater than 90% for most cases. Postoperative visual acuity in general, if the macula is attached prior to the repair, these eyes will do well and reach their pre-operative level. Macula off detachments result in damage or degeneration of the photoreceptors, and about 33 to 50% of these eyes with macula off detachment will attain visual acuity of 20/50 or better. Final visual acuity can also, though, be influenced by cataract, irregular astigmatism, persistent subretinal fluid, macular edema, or epiretinal formation. And because of this, I can't stress enough how important it is to spend time talking to these patients, letting them know that this may not be sort of a quick, simple fix. They need to be prepared for positioning and some of the factors that we know will happen, such as cataract after vitrectomy. They need to have realistic understanding, and they need to understand aspects of the care, such as altitude limits with gas bubbles that are in the eye. Thank you.